Thank you. Let me ask you a question. Who's in the healthcare setting? Doctors, nurses in the hospital? Hands up.
Who's a provider, medical provider?
Medical providers. Okay, that's good. How many of you think that your job will be replaced in the next 3 years by AI, not next 10 years, next 3 years? Hands up. Including the panelist. No? Okay, I'll answer the question at the end. Thanks for the opportunity. I'm going to talk a little bit about STIs, sexually transmitted infections. Definitely something you will remember for sure. It's skin, but different part of the body we are talking about. My name is Dr. Yudhara. I'm a consultant physician, board certified ER doctor, and an AI scientist with patents. So I sit in the middle of science, medical and engineering. So I left academia 2 years ago to start eHealth. So the problem statement is quite clear. When I see during the COVID, we had very good diagnostic tests, but there were a lot of people still sadly dying because it was not at the patient care point, which is at home. People cannot come to the hospital during the COVID. So we asked, how do we improve this situation? And when I look at another big part of the infectious disease, which is STI, sexually transmitted infections, the problem is massive. There's about 1 million new STIs every single day. And it's not a developing country problem as what most of us think. In US, 1 out of 5 people will have STI every single year. And the most shocking part to me was 50% of these cases takes 3 months to get a diagnosis after starting symptoms. Mark my word, after starting symptoms, not the asymptomatic ones. And we deeply analyze why is this so. The stigma in the STI is one of the massive problems. Because it's so stigmatized, people don't want to go and identify them in the hospital, say, I think I might have a problem, so can I get tested? And the second problem, in WHO report in 2023, talks about lack of awareness in the patients plus in the physicians. And clinical diagnosis of a physician of a STI is as low as 50% according to this WHO report. That's like flipping a coin and asking whether I have STI or not. So we couldn't take that as a yes. So we started our first product on to help men to detect STIs. So we basically do is, you can actually, if you see a symptomatic STI, like a rash or bump or something in your penis, you can take a picture, answer a few questions, AI will be able to screen the disease immediately within 5 to 10 seconds. And what it means to is, remember that 50% of people taking 3 months to get a diagnosis, of course we make them converted into a screening result so that they can see the doctor on the same day, so that hopefully the 3 months get 1 day and they will stop spreading the disease further. And if you see the news, we are having the worst syphilis crisis ever in US history for the last 300 years. And this is a very characteristic pathological state we can actually visually diagnose last time. So that's where I'm coming in. What it means is, when you have such technology, it's accessible anywhere in the world. As far as you have a phone and an internet connection, you can detect things. You can do it in your washroom. And from doctors, 50% clinical accuracy, we can actually push to common diseases like syphilis and HPV to 90 to 95% accuracies. Of course, we still keep it as a screening thing so that you will push them to the doctor to make the diagnosis. And the third one is affordable. In the population level, what it means is, to do a PCR, it costs about $200. This kind of digital test using your phone only costs about 0.1 cent. Imagine the impact at the population level. We can screen population level, large millions of people at minimum cost. That's what it is. And we didn't stop there. And then the next biggest feedback we got is, okay, we detect something. What am I supposed to do? And when we started the project, which is 4 years ago, AI was relatively still new. Gen AI was not there. But last 2 years, Gen AI was really changing things. And then we took the Gen AI again to help on this to augment our vision models. So if you look at big tech like Google, OpenAI, Microsoft products, they all blocks most of the sexual health related things. If you type the word penis, it's a medical term. They will then say, sorry, this is against my community guideline, I cannot help. So if a person having a problem, how are they supposed to get the information? All the social media blocks sexual health. It's not adult industry, it's actually medicine, but the truth is very different to get it out. So we train our sexual health companion based on AI agents, very sophisticated one, which actually can guide the patient through the journey and say, okay, if you've been detected with syphilis possibly, patient get freaked out, and they will tell what you're supposed to do. It's curable, and they will guide you through. And not only that, the recovery phase also, our vision models can detect from getting worse to getting better. Because we doctors take it as granted when patients say, oh, take the antivirals, you will go off. But when they go home, realize, oh, I took antivirals for 2 days, antibiotic for 2 days. Why it's not getting better? So some of these questions can be answered. So we put all these things, including telemedicine, in the loop, which we can actually cover most of the conditions within this ecosystem itself. That's what we did so far in the eHealth. And when we were doing this, 2022, WHO announced that the monkeypox is going to be a global emergency situation. And we realized we are in a very special situation at that point, because we specialize in sensitive topics like pathologies affecting penis or pathologies affecting the anus or vagina. And we built the world's largest data set on this. And we realized monkeypox was at that time affecting MSMs, men who have sex with men. And we had the right tools to build it. So we actually built the Mpox digital diagnostic test, or I would say Mpox screening test at that time. And then we launched it into the users as a beta screening test. And also I want to touch, so if you take a physical diagnostic test, it's a positive or negative. But the beauty of digital screening test, it can be actually trained to facilitate what you want to achieve in the outcome. So we call to action. So instead of you giving positive or negative, we actually, in the monkeypox, we put it Mpox as 3 levels, which is the red likelihood of you having Mpox is very, very high. And we guide them and tell them, okay, this is the nearest hospital which can fully treat your Mpox case. Of course, you go it, confirm it, get it treated. And the lower segment is what you call green, which is chances are very unlikely. But we collect so much data, and based on the behavioral part, we can actually see whether they are likely to get exposed very soon. And we can guide them to the vaccination center nearest to them and then get it sorted out. And the middle group is that not so sure, it's not negative, it's not positive. Beauty of a digital test is that you can do every day. If you want to do 2 times a day, you can still do it because the cost is so low. And when that crosses a parameter, which is the upper or lower, we tell them exactly what they're supposed to do. So that's the beauty of digital test. So it's very different from physical test. It brings very different characteristics, most importantly at the patient's hands. And those are some of the things we have done so far. And during this journey, we realized there was a lot of barriers. I want to talk about these barriers and then touch on the future part. One of the biggest barriers when I started this project is lack of data. It's so sensitive, nobody wants to clearly share their data. And what we did is we went to the medical literature, and of course we work with Lucky, my co-founder, is an openly gay man who very closely works with the gay community. We go and tell them and then said, look, if you don't mind, whatever the data you can anonymously share with us so that we'll use the model to train. Of course, we get the physicians to label it, but I still remember in the early days when we send the brochures, I sent a brochure saying that dick pic for science. I'm not joking. At least I'm trying to wake the people up. So with that, we still realize, me as a brown skinned person, when you take pictures, light affected our skin pictures much more worse than a white skinned person. So, and our accuracies are naturally dropping lower. So I didn't take it as a yes, but I want to innovate. So we created something called synthetic data pipelines, which is going to revolutionize the future of medicine of image-based ones. So what we did is, I'll give you a case we just submit to a Lancet for peer review. We built the world's first fully synthetic disease model, and that was performing better than any available actual data models because it's standardized to this color, standardized to the lighting conditions, and so on and so forth. And what it means is, again, as I said, we take the synthetic data generated. Now the technology is good. By the way, any of you can tell any of these pictures what is real and what is not, which is synthetic. Can anyone give it a try? We actually asked 10 dermatology professors around the world, and they all got wrong because these are all synthetic data. There's no actual data here which belongs to a patient. So at the early stage, what we did is, these are all preprints, so I'm sharing for the first time with the scientific community. So what we did is, we use synthetic data to fill the gaps of the brown skin so that actually the brown skin accuracies are same as a white skin. And that's what we sent to the Lancet for peer review. We are doing another second very interesting project. We are doing a synthetic data-based COVID pneumonia detection model. Of course, this is retrospective, there's more than 10, 15 models being published, including Google. We're taking 10 random chest X-ray images, just 10, not thousands, not hundreds, just 10. Using that, we are building thousands of synthetic images, which is shown in the picture. They're all synthetically generated ones. And use that to train a model and see how it performs. We have the early results. Actually, we are performing better than all the models which was trained before. And I think with this, it's going to revolutionize. This is what the future looks like. All the models my colleagues have talked about, we can use synthetic data in very specific blind spots of your models to improve those blind spots. That's what it is. And of course, soon there will be models fully synthetic. That means there's no patient data at all. Imagine that when you handle the patient data, all the FDA clearance and then HIPAA compliance, everything will be much, much easier because this data does not belong to patient. So this is the future. Of course, it's relatively early, but things are changing very, very fast. What it means is, again, we will be able to build models super fast, and especially in the rare diseases, which we're working on a model for penis cancer, which is a lot of people, again, don't want to go to hospital as the first thing, but we can screen them at the home. We build most of the data using synthetic. And the third part is, as I said, the removing the bias. So that bias from the light, bias from the skin color, and all the other things, we can actually standardize using synthetic data. That's what the future looks like, actually. Okay, coming back to the question I asked. So even as a scientist, engineer, and a physician, it's so difficult to keep in pace with the technology changes. AI is going to change so much in every direction. I don't think it'll replace a physician in 3 years, but I for sure tell you, people who adopt AI into their practice will survive better than the people who don't. And I'm very happy. I see a lot of people who's in this room, which are already adopting or trying to adopt the AI, so you guys will be fine. Thank you so much for the